what are the problems leading to this result? I mean, do we actually really looking into the data of the railroad trial? Is that fair of using the data that to solving the problem? I think it is in a surgical randomization. I think it's really hard. It's like an experimental surgery versus a standardized surgery. Usually, with surgeon variety, that makes what makes a difference. So, surgeon variety or surgeon experience would makes the distortion out, will distort the outcome of the trial. So, if we explore looking into the potential learning effect in the roller trial, that's been published this year on the it's an open access paper. That showing that if you look at the roller trial on the laparoscopic side versus the robotic side, actually it's very interesting. I'll just show you the data. Majority of the surgeon participated in the roller trial has more experience in the robotic side. While when patient randomized, they have less experience in robot surgery. So this, if you look at this cubic, I mean, look at this. On the left side, majority of the participating surgeon has well experience in laparoscopic surgery. So laparoscopic surgery is more a standard surgery. And if you look at the right side here, only a few surgeons are experienced with robotic surgery. So these means that a lot of surgeons has less experience in robotic surgery. So this might alter the trial, the result of the trial. As you look at, if the surgeon perform more than, it doesn't matter how many laparoscopic experience you have, if the surgeon perform more robotic surgery, the odds ratio will come down. So which means that the more you do, the better you are in robotic surgery. So when the surgeon has more robotic experience, he has less conversion to open surgery. And this is also showing that the more robot you do, the more experience you have, the less conversion it is. Also, by group, it doesn't matter how many laparoscopic surgery you do, it does not alter. It will related to how many robotic surgery that you do as compared for conversion. It means that if you do 300 surgery laparoscopically and you only do 2 robotic surgery, and then per year you will have high conversion rate when you do a robotic surgery. So if you do 45 cases of laparoscopic surgery, but you do 100 robotic surgery, you have less conversion rate. So the more you do, the better you are. This is also showing that too. Okay. So these are the data showing. So in conclusion, after you carefully looking at the data, I think robotic surgery does in fact confer an advantage as compared to laparoscopic surgery in terms of risk of converting to open surgery. So what's next? After the trial, many of the surgeons say that maybe we should not do robot. Are we going back to the future doing open surgery? No, I don't think so. I think surgeons fail to keep up pace with the technology. The technology was really fast. So I suggest that if you look into your own data, and then I think the more you do, the better you are. For example, if you look into your own data, this is a single surgeon data coming out from Korea University, showing that if you do, Professor Kim is a very experienced doctor in doing a robotic surgery and laparoscopic surgery. And he looked into his own outcome. As he looking into 732 patients and 272 robotic surgery versus 260 cases of laparoscopic PME, and he looked at his own result for long-term oncologic outcome. I'm not going to look into the methodology. I mean, all this is pretty much standardized. So because of time factor, we'll move on to see the result. So on the robotic side, as the younger, the patients are younger on the robotic side, and lower tumors on the location of CRT. But you just come and look at directly look at the result of his data. I'm sorry. So robotic shows an increase of overall survival as compared to laparoscopy. So if an experienced surgeon always doing laparoscopic surgery as well as robotic surgery, it seems that robot produce better outcomes as compared to laparoscopy. A trend toward moving the overall survival. And also cancer-specific survival is better in robotic group. And also disease-free survival is better in robotic group. Therefore, I think robot in good hands will be a better, a very good tool. So if you're well practiced, well trained on your robotic surgery, I think robot is a much better surgery for rectal cancer surgery. So it's safe, and long-term oncologic outcome is safe also. I think it's an alternative treatment, like Simon just said, this will be a platform. But so looking into our own data, I'm just going to show you our data. We started out with hybrid procedure, and we did not convert with any of our first 25 cases. And these 25 cases were all low rectal cancer with a distal margin in an average of 2.8. So we're doing a lot of robot nowadays. And then we switched to the hybrid, single docking using the method like Professor Kim. So also the conversion rate was 0. So now we have 96 cases. We did not convert into any open surgery or laparoscopic surgery or robotic surgery. And then I think in the future there are more robots to come. I'm not going to go over this. Because of time factor, if you look at we believe that the estimate time at which key trend will have the greatest impact. I think robot currently will have the most impact in surgery. I think robotic surgery is a platform, like Simon had just said, and will be the future surgery, and it will not replace surgery, at least by 2035, right? So, like he said, robots should work with AI, and at least for doctors like colorectal surgeons, I think robotic surgery should be working with AI. And at the end, I like to conclude that if you look back in the year of 2002, when we were doing laparoscopic surgery, I often got punished by our older surgeons doing the meeting that when I present laparoscopic surgery. And this was the slide that I took from a Simon's meeting a few years back. If you look at the open colorectal surgery, it was well established. No short learning curve, clinical evidence, and oncologic safe and cost-effective, accessible operating time. But if you look at laparoscopic surgery back then was a new technology and not enough evidence. Oncologic safe was questioned, and cost effectiveness and long operating time and skill gap. But if in 2008, it's the same for robotic versus laparoscopic surgery. I'm just moving the laparoscopy here, and I put a robot here. It's the same. So I think by looking in a trial, I don't think you can conclude that robot is not a good tool. I think in the future, robot will be a tool. Thank you very much for your attention.
Thank you.